And now I would like to invite all the speakers. I don't see Professor Dimino actually in the list, so I'll just invite Professor Yorio and Dr. Kitchen to for an open questions from the audience. All right, I don't actually see any questions written in the chat for any, but I do actually have just a quick question for Dr. Kitchen. Now, with all the complex, not the complex available product, but with the many products are available, including now also the non-factor products, it's sometimes difficult to choose which is the best test to check for factor 8 level. Now in our lab, we actually do both tests for the 1-stage as well as the 2-stage chromogenic assay in all kind of testing. So we're not actually selecting any specific patient category, but anybody who is actually requiring a test for a factor level, we send for both. What do you think? Should we just do the 2 tests regardless?
Yeah, I think there is a problem with the if technical can solve it. Meanwhile, we can move to Dr. Orio. If you allow me, better, I have a question for Dr. Orio until Dr. Steve.
Yes, please go ahead. Go ahead.
Thank you, Alfonso, for interesting talk. And I think the WAPS is a promising web-based model for calculating the BK, and personally I had used it and found it useful. The question is, as we all know, that the prophylaxis is the goal for prevention. However, again, I need to hear from you about the cost reduction with the reduction of the amount get infused by using the BK, especially for those who have a limited resources or have a problem with having enough doses or enough cost to cover the whole doses. If you can highlight on this point.
Yes, it's a very interesting question. Thank you for asking. I will make 2 points. One is about the value of tailored prophylaxis when you use low doses. So in China or in Japan, but in China even more so, that is what is called low dose prophylaxis. They treat patients with lower doses than we do, even down to 10 or 5 units per kg. There is still value in tailoring that approach between 5 and 10, between 5 and 15. There are patients that are okay with 5 and others that require 15. And you can always use a PK as a tool to convince parents of small children or patients that is worth infusing more often. You can always increase the dose, the trough you obtain by giving more frequent infusion. It will decrease the total dose. It will increase the result. That's one point. So yes, PK can be used to make optimal use of limited resources. The other way that POP PK help us reducing consumption is avoiding us to do useless mistakes, like having, a variable dose where you do, I just make an example, Monday, Wednesday, Friday treatment, and you give, say, 2,000, 2,000, 3,000 on the Friday. The 3,000 doesn't make any difference. Any dose difference that is not doubling or tripling the dose has no impact on the trough. So there's a lot of waste around habits that we developed without exactly knowing what we were doing. If one was to cast those treatment into WAPS, they will see that there is no difference. Like going from 2,000 to 3,000 in a 70-kilo patient without changing the frequency. Very likely the trough just change of a decimal. So there is a lot of education for doctor and patient showing what does make sense. My last point is that on average, tailoring doesn't change how much you spend on a population, even assuming you don't consume less or more in a country or in a region, you will still be distributing units where they are needed. Patients that happen to have a very long half-life, very positive PK, they will not bleed even at a low dose. Everyone tells me it's difficult to reduce the dose to a patient. Yes, it is difficult, but you can take the occasion of a switch, and when you switch to a new concentrate, you start with the proper dose, and we are building a lot of science around how to predict the dose after a switch from the current concentrate to make sure that we try to use across the population the amount we have available at best. So these 3 points I would make in response to your question. Hope that this is useful.
Thank you.
There's a question in chat. Is he likes information on the type of assay and reagent that are usually do in concentrate. We are not, you submit a picture, tell us to choose from a list which reagent you are using, and we are starting to investigate if all the differences that is in the lab are really to account the test. Of course, but even among those approved, there are minimal differences, and we are trying to understand if we can include those in the model and build on that.
Thank you. Dr. Badr?
Excellent. Is Dr. Kitching still able to access the mic or not yet? So still have the same issue. All right, perfect. Now I could see Professor Dimino have joined us. Buonasera, Professor.
You are muted, Giovanni.
Mute. Yeah.
Excellent. All right. We have 2 questions for you, Professor Dimino. The first question is, could the convalescent plasma used as a plasmapheresis in case of immune-compromised patient with an history of TTP?
Say again, sorry. In immune-compromised patients with a history of TTP?
A history of a TTP, exactly.
There is no evidence whatsoever concerning the specific issue. In reality, there is some old information concerning the specific issue. However, the new monoclonal that is now available overcomes this possibility, because the possibility to achieve good results just by using monoclonal reduces the need for using convalescent plasma under those conditions.
Excellent. Thank you very much, Professor. The second question goes as, does it applicable to extract plasma-derived antibodies from convalescent COVID-19 patient, then use it to produce a monoclonal short-term antibodies?
Well, in reality, the problem that now is present in the area is that by isolating monoclonal antibodies, by isolating antibodies from convalescent plasma, you isolate IgG, not IgM, that are missed during the preparation. So the reason why presently some drug companies are working on monoclonals and specific type of monoclonals is just to overcome the specific issue, because for some germs, for some pathogens, IgM is very important from a practical point of view, and the reason why it is important to overcome this issue is related to the need of preparing IgM specifically. There is a drug company in Australia working specifically on this issue and getting very good results.
Great, very well done, Professor Dimino. From my end, I don't have any further questions. I will just wait for Professor Tariq if he had any questions. I think Professor Tariq is also not with us. Excellent. I would like then to thank all our speakers for their time and with sharing their expert opinions in the 3 topics. And have a very good afternoon and evening for everyone. Thank you very much.
Thank you.
Thank you.
Dr.
Ciao.
Ciao.
Arrivederci.
Thank you very much.
Ciao, Alfonso. Ciao.
Bye.
Ciao.
Have a
Thank you,
good
Alfonso.
time. Enjoy.
You too. And thank you, Steve, for not, unfortunately, we couldn't hear your voice live today, but definitely you are with us. I would like to thank also Dr. Badr from Oman, who nicely moderated this interesting session. And I think time now to go and visit the virtual exhibition for 15 minutes, which will be also the break before starting the next session at 9:10. And that session also will be an interesting session. And till we see you in 15 minutes or so, we wish you to visit the virtual exhibition and see the videos uploaded there. Thank you for joining us.
Thank you.
Thank you.
Thank you for
Thank you
inviting.
very much for inviting.
Bye. Bye.
Thank you all. Bye.
Bye.